until another fracture occurs. And when the fracture occurs, the most common sites are the proximal femur, distal forearm, vertebra, and these fractures causes patient to suffer from pain, limited range of motion, disability, and deformity. And these causes the psychosocial symptoms like depression and loss of self-esteem. And another important, the osteoporotic fractures increases the risk of future fractures, and therefore the morbidity and mortality also increases. The financial impact of osteoporosis is huge, that it increases the economic burden in relation to the patient's hospital stay, bed stay, overall costs, and surgical treatment. The prevalence of osteoporosis worldwide, that 1 in 3 women and 1 in 5 men over the age of 50 years experiences osteoporotic fracture, and a bone breaks in every 3 seconds due to the osteoporosis, and it's only the second health problem next to cardiovascular disease. In India, 1 in 8 males and 1 in 8 females over the age of 50 years suffers osteoporosis, and when compared with the Western countries, the incidence of age is lower. In India, the increase in osteoporosis is generally seen due to the increase in life expectancy of the people and also the increase in population. So what is the pathophysiology basically in osteoporosis? The bone remodeling is a very tight balance process. When there is an imbalance between the osteoclastic and osteoblastic activity, this causes the increase in bone resorption and the formation, and that leads to osteoporosis. So what are the causes of osteoporosis? The lifestyle factors, most importantly alcohol abuse, smoking, vitamin D deficiency, inadequate physical activity, low calcium intake, and immobilization. The other causes of osteoporosis like genetic disease, hemochromatosis, homocystinuria, androgen insufficiency, Turner syndrome, thyrotoxicosis, diabetes, hemophilia, rheumatoid arthritis, ankylosing spondylitis, stroke, the medications like anticonvulsants, anticoagulants, heparin, and methotrexate. How you diagnose? Based on history, physical examination, BMD testing, and vertebral imaging and biochemical markers of the bone turnover. Physical examination may reveal the occult fractures, and it's a very easy method. You can measure the occult fractures of thoracic vertebra by wall occiput distance. If it increases, you can suspect. The other is a rib pelvis distance for the lumbar vertebra. Bone mineral density is important component in the diagnosis of osteoporosis, and WHO also defines osteoporosis in terms of bone mineral density, and it's measured by dual X-ray absorptiometry known as DEXA. Normally, the bone density is within 1 standard deviation of peak bone mass. Osteopenia said when the bone density is between 1 and 2.5 of 2.5 standard deviation of young reference people. That is, the T-score is between -1 to -2.5. Osteoporosis is defined when the bone density is 2.5 standard deviation or more below the young reference population. That T-score is equal or more than less than 2.5. What are the indications of bone mineral density? Regardless of the clinical risk factors, women aged more than equal to 60 years, men aged more than 70 years, and with the clinical risk factors for the fractures, young postmenopausal women, women in menopausal transition, men aged between 50 to 69 years, adults who have fractures at or after the age of 50, adults with conditions like rheumatoid arthritis or taking medicine like glucocorticoid associated with low bone mass and bone loss. Its major sites are mainly the hip, and in hip, the femoral neck, Watt's triangle, trochanteric area, and the intertrochanteric region. And in spine, it's from the L1 to L4 vertebra. Why BMD test is important? Because it establishes or confirms the diagnosis of osteoporosis and also predicts the future risk for fractures, and also monitoring the patients who are on treatment. And it also measures the T-score and Z-scores. So what is T-score and Z-score? The T-scores is patient's BMD value compared with that of control subject who are at their peak bone mass index. And Z-score is the BMD value compared with that of persons matched for age and sex. Both were measured by DEXA. Vertebral fractures is one of the consistent findings in osteoporosis. An established radiological fracture shows sign of impaired bone quality and strength, and is a strong predictor of new vertebral and other fractures performed by using lateral, thoracic and lumbar x-rays, and also by lateral vertebral fracture assessment using DEXA. The presence of single vertebra fracture actually should be imposed on vertebral imaging. The patient, woman age equal or more than 70 years, all men age more than or equal to 80 years, and T-scores at spine and hip or femoral neck less or equal to 1. All women age between 65 to 69 and all men age 70 to 79 with T-score at spine and hip is equal or less than minus 1.5. The postmenopausal women and men age 50 and older with the specific risk factors like low trauma fractures during adulthood, historical height loss is either 1.5 inches, prospective height loss in subsequent measurement is 8.8 inches, that is 2 centimeter or more, or recently ongoing long-term glucocorticoid treatment. In human beings, the bone remodeling occurs throughout the life, and the biochemical markers of remodeling are the resorptive markers, which are serum C talopeptide and urinary and talopeptide, and the formation markers like serum bone-specific alkaline phosphatase and osteocalcins measured. And evaluating these biochemical markers, this predicts the bone turnover by risk of fractures, rapidity of bone loss, extent of fractures, risk reduction after treatment, magnitude of bone mineral density increases with the treatment or not. This can be assessed with the biochemical markers. WHO developed a new tool known as FRAX to evaluate the fracture risk of patient, and also develop an algorithm which gives 10-year probability of the fractures. What are the risk factors included in WHO risk assessment tool? These are current age, excessive alcohol intake, parental history of hip fractures, secondary causes of osteoporosis, and there are different questionnaires to calculate the FRAX score. When you put these answers into the questionnaire or into the sheet, you find the score, and these scores helps in the management and further monitoring of the patient. The additional tests are CT-based absorptiometry, clavicular bone score, peripheral dual X-ray absorptiometry, quantitative ultrasound densitometry. The management falls into two basic criteria. This is general recommendation and pharmacological therapy. So what are the general recommendations? The adequately daily intake of calcium and vitamin D. The National Osteoporosis Foundation an Institute of Medicine recommended 1000 milligram per day of calcium for men aged between 50 to 70 years and 1200 milligram per day calcium to women aged more than 51 and equal or men aged more than 71. The study shows the reduced rate of fracture when using combination of vitamin D and calcium. The NF recommended also 800 to 1000 international unit of vitamin D per day for adult age 50 and older. In vitamin D deficient individuals, the high dose of vitamin D for at least 8 to 10 weeks to maintain the target level of around 30 nanogram per deciliter, and this followed by a maintenance therapy of vitamin D to maintain the target level. The other general recommendations are regular weight bearing, muscle strengthening exercises, fall prevention, cessation of tobacco use, and avoidance of excessive alcohol. The strategies for prevention and treatment of osteoporosis, there are different interventions taken like exercise, calcium supplements, dietary calcium, smoking cessation, reduced alcohol consumption, and these all shows increase in BMD and reduce the fracture rate in the spine and hip fractures. The pharmacological therapy is indicated in the postmenopausal women and men aged 50 and older with the following like vertebral fractures and or hip fractures. Hip DEXA or lumbar PA spine is scored less or equal to -2.5, low bone mass, and the 10-year probability of the hip fractures more or equal to 3% on a FRAX algorithm, and the 10 years probability of the major osteoporosis related fracture equal to or more than 20% on a FRAX algorithm. The pharmacological therapy basically divided into two groups. This one is anti-resorptive medication and anabolic medications. The anti-resorptive medications are bisphosphonates, calcitonin, estrogen antagonist, agonist, and other tissue-selective estrogen complex. The anabolic medication is the parathyroid hormone, the teriparatide.